Thank you, Dr. Rubinos, for that wonderful talk. I learned so much about all the work that's being done in the... Is this the mouse on?
Go to this arrow right here. With the mouse.
Ah.
Yeah, and then the first one has to... There's nothing on that. Oh, gotcha.
No, no worries. I like to talk with the pointer, sorry. Yeah, thank you, Dr. Rubinos. This is a wonderful talk. I learned so much. So I'm going to be talking about repetitive and periodic patterns, how that relates to this idea of the Ictal, Interictal continuum, and then go a little bit into diagnosis and management. We have some cases after this, and I think that's a better forum to discuss much of that. Disclosures, I've received a grant from a company, but I will not be discussing that data. Then the NINDS and Lily's fund. So here are 3 learning objectives. What are rhythmic or periodic patterns? I know there's kind of a mixed group that often comes to the AAN, so it's probably worthwhile just to discuss, what are these things that we're talking about before we get into more depth, and what is this concept of the Ictal, Interictal continuum, and then a bit about how to approach diagnosis and management. As you can see, I have a lot more question marks there. All right, so first, how common are these things? So we started to do a lot of digital EEG, in the late 90s, early 2000s at select centers, largely in the US. When you started to see these initial studies published, there are very high rates of seizures associated with hooking up an EEG with somebody with altered mental status or some kind of paroxysmal clinical event in the ICU. But now, there's a lot of centers that have started using this quite broadly. And we have gotten rid of a little bit of that selection bias, and I think we have a better idea of exactly how common these kind of patterns are in the ICU. And this is a recent study looking at the Critical Care EEG Monitoring Research Consortium data. At this time, they had around 12,000 patients who had been entered in this database. You can see here they have different underlying etiologies. And then this is any seizure. The red is status epilepticus. But what we're talking about more here are the rhythmic and periodic patterns. And based on this study, it's around about 30% of them or so will have some rhythmic or periodic pattern. What the significance of that is, we'll get into a little bit more, but it's around 30% of patients who have altered mental status in the neuro ICU will have something of interest on their EEG. And I think there's another study that's held up over time by Dr. Clausen and Hirsch when they were at Columbia, looking at if you have a patient who has a seizure on EEG, will they have ever had a clinical seizure during the course of their stay, some kind of positive clinical manifestation that would be consistent with a clinical seizure. And it's really only about a quarter of those patients will have had a seizure that was evident. So the important point here is that you need to use EEG if you want to try and find these things. You can't rely on only having a clinical seizure. Those are the only patients who ever need to be hooked up to EEG. You need to start screening more patients broadly. But first off, what aren't rhythmic or periodic patterns? Of course, things that are seizures. And in the last ACNS terminology, they really defined what they consider a seizure, which is quite a useful starting point if we want to look at things that are getting close to seizures. So epileptiform discharges that are over 2.5 hertz and over 10 seconds, that's a definite seizure. Any patient or any seizure that has definite, any rhythmic pattern, I should say, that has definite evolution and goes over 10 seconds, that's a seizure. Any pattern that is associated with a clear clinical change associated with it, that's also a seizure. And then, there's a bit looser criteria that if the pattern responds to treatment and they get better, well, then we know in retrospect that also was a seizure. So, we never like to define things based on response to treatment, but this field is still developing quite a bit. So we still have that in the criteria. So first, what is a focal electrographic seizure? What's the kind of canonical definition? And the way this was explained to me is a seizure is like a story. It has a beginning, it has a middle, and it has an end. That's what we mean by evolution. It starts, it changes, and then it stops. So here's a seizure, beginning, you can see it evolve. It has a middle, seems to evolve, change in amplitude, change in frequency, not so much in morphology here. Now you can see it even starts to change in morphology, slows down a bit, and then it ends. So that's evolution, that's a seizure. What about a pattern here that wouldn't meet these EEG criteria that we have for seizure, but the patient has this change associated with it? Has some clonic movements associated with these discharges. So then you would say this is an electroclinical seizure, so we know what that is. Then I hope we all know what this pattern looks like and what we need to do, but over 2.5 hertz, goes on for more than 10 seconds, by criteria, a seizure, goes on for more than 10 minutes, and if there isn't a clinical change, there are different definitions for a convulsive status epilepticus, but for electrographic only status epilepticus, you say it has to last 10 minutes of this, then it's status, or in the newer terminology, also if there's any given hour within an EEG that has over 20% of the recording to have a pattern like this, that's also considered electrographic status epilepticus. So this is what rhythmic and periodic patterns in IIC are not. This is the upper limit. Once we see these things, these are seizures, and we treat them as such. But what about these things that don't quite get to that criteria? So I really encourage everybody to review these guidelines, to get the testing associated with naming these patterns, especially if you're an EEG interpreter. But what you essentially have are two terms. So a main term that refers to the localization, and then the second main term, which is, is it periodic discharges, is it rhythmic delta activity, or is it spike wave? And generalized refers to being in both hemispheres synchronously. Lateralized means it's in one hemisphere. Bilateral independent means it's in both hemispheres, but they kind of march at the beat of their own drummer, right? They have different clocks. They seem to be coming from independent sources. And then there's multifocal, when you have 3 of those kind of independent generators, and then the newer term in the 2021 is unilateral independent. So you can have, basically bilateral independent discharges, but they're not bilateral. They're both in one hemisphere. And then you have periodic discharges, rhythmic delta activity, or spike wave. So let's discuss that a little bit more. What does it mean for something to be periodic? It means you have a discharge, then you have some kind of space, and then you have another discharge, and it's consistently the same inter-discharge interval. Rhythmic just means there's no inter-discharge interval. The pattern, is continuous. And, there's been different nomenclature for this over the years, but I think it's worthwhile because a lot of this nomenclature is still used, and there's nothing, inherently wrong with it, but just so that everybody's discussing the same thing. So PLEDs, periodic lateralized epileptiform discharges, would now be called lateralized periodic discharges, kind of got rid of the epileptiform element of it. GPEDs, or generalized periodic epileptiform discharges, is now generalized periodic discharges. Frontal intermittent rhythmic delta activity, often called FIRDA, that would now be generalized rhythmic delta activity with a frontal predominance. TERDA, or temporal intermittent rhythmic delta activity, would now be a lateralized rhythmic delta activity. So here's an example. See, one of my fellows here, he better know this answer. What are these generalized periodic discharges? So in both hemispheres, synchronously, there's an inter-discharge interval. So what about this one? So this is left temporal, left parasagittal, right parasagittal. So it's only in one hemisphere, it's in the right hemisphere. You have these rather periodic discharges. So this would be lateralized periodic discharges. Now here's one, you see left parasagittal, right parasagittal. See, they're periodic, they don't seem to run into each other, but they're not really synchronous between the hemispheres. So bilateral independent periodic discharges. Then here's a pattern. It's this is left parasagittal, right temporal, or left temporal, right temporal. See this rhythmic pattern, right? There's no inter-discharge interval. It's all continuous with each other. It's only in one hemisphere. So lateralized rhythmic delta activity. Here's a very similar pattern. Again, lateralized rhythmic delta activity. Now here's one where you see a rhythmic pattern again, but now it's in both hemispheres at the same time. So it's generalized rhythmic delta activity, otherwise or traditionally called FIRDA, frontal intermittent rhythmic delta activity. All right, so that's what rhythmic and periodic patterns are. So now we kind of are all on the same page with that. So what is this idea of the ictal interictal continuum? And Dr. Rubinos was very adamant that I stress this point over and over. The ictal interictal continuum essentially means possible seizure or status epilepticus. We don't have enough information just on the EEG to make that determination. And we already discussed what an electrographic seizure is, what an electrographic status epilepticus is. So that's the upper limit. It can't meet those criteria because if it meets those criteria, we know what it is. So it's not quite there. But now, if you have a periodic or spike wave pattern that's over 1 hertz, but less than that 2.5 hertz, which would be the criteria for an electrographic seizure, and over 10 seconds, that's considered ictal interictal continuum. If you have a periodic pattern or a spike wave pattern that's at least 0.5 hertz and then has one of these plus modifiers on it. So this is classically called PLEDS plus. So you see a discharge, one of these periodic discharges, and on the descending limb you'll see this fast activity or you'll see this rhythmic activity. That's for a long time been well known that that's a higher association with seizures and in and of itself is more likely to be a seizure or possible electrographic status, basically. So we have special criteria for that. And then lateralized rhythmic delta activity that's greater than 1 hertz, lasts 10 seconds, has a plus modifier or has fluctuation. So it has this kind of not quite evolving in the way that we would canonically associate with a seizure, but it's not static. It kind of moves around a little bit. We're always a bit more suspicious that that's going to eventually evolve into a seizure. So here's just an example of the problem that we're up against. So here's a patient that had myoclonic movements associated with these discharges. So these are lateralized periodic discharges. As we've learned, they're maybe around 1 hertz. If I just saw this without a clinical change, I probably wouldn't be that excited about it. But because there is a clinical change, we say this is electroclinical status epilepticus, and everybody is up in arms, and we give them a bunch of medications very quickly, and it's almost considered a medical emergency. But here's a patient who has 2 hertz LPDs with some plus features associated with it. So to my eye, this is a much more aggressive electrographic pattern. And this is considered on the ictal interictal continuum. So how can we say that one EEG is more benign, but it's a more serious medical condition, one EEG is more aggressive, but it doesn't really meet these criteria that we associate with an electroclinical seizure? How do we square this circle? And one reason we could say that this is because scalp EEG is very limited. We only see very little bit of the surface brain. There needs to be a lot of synchronous activity. Some people say around 6 centimeters squared before you see any real change on the scalp EEG. Where? Is it in the gyri? Is it in the sulcus? Is it deep? Is it in the insula? Of course, you're going to see things very differently on the scalp. Is it associated with eloquent cortex or like the motoric regions, and that's why you see these positive clinical manifestations? Does that really mean that it's inherently different and we should treat it differently? We don't have a lot of answers to these questions. Or maybe it's that EEG in and of itself is insufficient to really understand the pathophysiology of what's going on in these patients. Maybe we need other elements. Maybe we need imaging, perfusion, metabolism. Those are the ways that we really figure out what's going on with these patients and how we direct management. So we're left with this kind of conundrum within EEG that it can't really sufficiently answer all of the questions that we're interested in. And that brings us to this idea between the ictal interictal continuum hypothesis. And you have 2 axes here. You have potential for secondary neuronal injury, so secondary brain injury that we think is associated with that pattern. And that's on the vertical axis here. And then on the horizontal axis, is it interictal or ictal? And what do we mean by this? We mean that if I was somehow magically able to take away that pattern, does the patient's neurologic exam improve? And these 2 ideas aren't really orthogonal. They're not really completely independent of each other, but they have some degree of independence. And Traditionally, we would say generalized convulsive status epilepticus, we have a lot of data that that's going to damage the brain. Nobody's going to argue that that's not a seizure. But then we have focal motoric status. Nobody's going to argue that that's not a seizure, but does that really cause secondary brain injury? And, to some extent it can if it goes on long enough. You can see the homologous regions start to get kindled, but people can go on this for months and months and they don't seem to have a lot of residual deficits associated with it. But then we have all of these kind of patterns, and this is using some of the older nomenclature, where we're not exactly sure. When is it ictal? When is it not ictal? When is it going to potentially cause secondary injury to the brain? And this is a study by Dr. Zafar at MGH. And she looked at 2,000 patients from the neuro ICU. She looked to see who had these patterns, and she shows this dose response curve that the burden of these patterns that you had in any given day, it was associated with a worse outcome. So you have this dose response curve. That's something you like to see in science, but it's not necessarily causative. I mean, you could say, Dr. Struck, well, of course there's the obvious confounder. The severity of the brain injury is going to make it more likely that you're going to have these patterns, and of course the patients are going to have poorer outcomes. That doesn't necessarily mean that the pattern in and of itself needs to be treated or that the pattern is what's causing the poorer outcomes. We saw this in the Telstar trial where we were looking at patients post-cardiac arrest who had GPDs, and we tried treating them, and nobody really got better. As Dr. Bleck, who I think was here, had said, this is a symptom of dying brain, and treating it aggressively is probably not going to improve patient outcomes. But here's a quote from Dr. Fisher that I like to think about when I'm trying to think about these problems. And what he says is, we were really lucky with epilepsy and EEG. This technology kind of developed. We start hooking this up to patients with epilepsy. We have this beautiful biomarker. We see spikes. We see these patterns. But maybe we become too focused on EEG. Seizures are a lot more than the changes that we see in terms of the brain electricity. There are changes associated with metabolism. There are changes associated with network connectivity and blood flow. And maybe some of these elements are really just as intrinsic, as important as the actual electrographic signature. And a few studies have kind of followed up on this concept. I said that there's this dose-response curve, but do we have any evidence that these patterns in and of themselves can cause secondary brain injury? This is a study out of Columbia looking at patients with aneurysmal subarachnoid hemorrhage. And what they show here is that the frequency of the discharges, so how fast they are next to each other, that once you start to get up to around 2 hertz, especially around 2.5 hertz, you start to see this drop in oxygenation. So there's metabolic consequences that seem to be associated with these discharges. And another very famous study from UCLA looking at patients with traumatic brain injury, looking at microdialysis. You see a very similar phenomenon. This is the lactate to pyruvate ratio. So as these discharges are occurring, you'll see there's an increase in lactate. So another indicator that there's metabolic stress happening. And here's another study looking at FDG PET. And what you can do with that, so a marker of metabolism, you can look at the SUV, so the standardized uptake value relative to some other part of the brain that's not being involved in the pattern. And you can see as that pattern increases in frequency, there's an increase in the metabolic demand in that area. And what's kind of interesting with these FDG PET studies is that you see that maybe the EEG looks relatively focal, but when you look at the FDG PET, you'll see that the hypermetabolism is often much broader. It'll often involve the thalamus, the hippocampus, sometimes the basal ganglia. It can be really focal, like as in this patient, or it can be a bit broader as in this patient. So really the EEG, because of its spatial limitations, it's really only giving us a little slice of what's going on in these patients. And there's a fairly linear relationship between the frequency and the metabolic demand. There's another study doing FDG PET on these patients from Hopkins. And what they showed is not only is it the frequency, there are some other elements of the pattern that seem to be associated with hypermetabolism, particularly if the pattern has a more of a spike-type morphology, and if it has, I think maybe the most important finding associated with this is if it has that fast frequency. So it's not just the periodic discharges and their frequency. It's that rhythmic fast activity that you often see. That in and of itself seems to have metabolic consequences. So now we can conceptualize the IIC, not just as these two axes, but another axis put on top of it, the potential metabolic demand. And maybe that's a way of trying to further figure out which of these patterns need to be treated, at least which of these can be associated with secondary brain injury. And is this uniform across patients that everybody can tolerate up to a certain degree, or is it quite different in patients who have maybe impaired autoregulation, some other kind of decrease in the metabolic reserve or decrease in the ability to cause excess perfusion that you would need to sustain enough blood flow to somebody who's having an electrographic seizure. So when I talk about the IIC, I like to use this metaphor. So when you buy a suit coat, this is what the person will tell you. They'll tell you, you always have to button the middle button. I'm not sure why, but that's what you're supposed to do if you want to look proper. You're never supposed to button the bottom button. So these are the non-IIC rhythmic and periodic patterns. And the one that you're always supposed to treat are seizures and status epilepticus. And then this top button, that's dealer's choice. You can decide whether or not you button that one. And that's the Ictal Interictal Continuum. And to stress this again, that means it's possible status epilepticus or an electrographic seizure. So here's just a few examples. So here's a patient who has periodic discharges, right? But they're pretty slow. This is, not even half a hertz. So this would be non-IIC. Here's a patient with lateralized rhythmic delta activity, and we said that sometimes can be associated, or it can be on the IIC, but you have to have plus features with it, or you have to have fluctuations, and it has to be greater than 1 hertz. So this would be not IIC. But lateralized rhythmic delta activity is independently associated with a risk of seizure, so maybe this patient would still need to be monitored to look for discrete electrographic seizures. Here's generalized rhythmic delta activity, right? We didn't mention this at all when we were discussing the IIC. So generalized rhythmic delta activity, not really associated with an increased risk of seizures, and also not IIC. Here's one that's 2 hertz with plus features, so this is IIC. And here's one that's kind of really close to that border, about 1 hertz, has some plus features associated with it. Maybe, I don't know. That, I think, is the IIC of the IIC. All right, so how do we approach diagnosis and management? So as I said, maybe EEG is not enough, so we have to start looking at some other modalities. So if you have a clinical correlate, electroclinical status epilepticus, then drug trials, Ictal SPECT has been used, FDG PET, I think MRI with perfusion is becoming a more commonly used modality. You can do local probes if you really have a center that has quite a few abilities. You can even trend NSE if you would like. So this is a nice paper that was recently published. I mean, we've all tried these, either benzodiazepines or anti-seizure medications. Some institutions have this well protocolized, but nobody's really come up with standardized guidelines. So here they say these are the medications that you should try. And I think this is maybe the most important part. You can't give them 500 milligrams of Keppra and say that that was an adequate trial. You have to give them a decent dose of drug and see if they respond to it. And what do you want to look for? You want to look for an improvement in the EEG, either more than 1 minute of resolution of the IIC patterns, or using the rule of 3 times the previous longest segment. And then you want to look for clinical improvement, and they provide a scale that, if you improve a level or so, that's suggestive that the pattern is responsive to anti-seizure medications. How would you use FDG PET? What's nice about FDG PET is you get, the whole brain. You get basically around 30 minutes of the metabolic activity, so you want the pattern to be really well established. You don't get this really brief snapshot. It's just really hard to get at most centers. MRI can be useful. What you want to see is increased DWI changes in the context of increased perfusion within that area. And it's not quite as well studied, but I think is emerging as a useful technique. Here's just a study briefly looking at status epilepticus, so ongoing ictal pattern versus somebody who just had a few discrete seizures, so not having a seizure during the MRI, presumably. And you can look to see that ASL, so increased perfusion, is a very sensitive marker, and DWI changes is a very specific marker. Similarly, if you have the luxury of invasive probes, you can look for, decreased or increased lactate, decreased oxygenation associated with the pattern. So then, this is briefly the treatment approach as I see it. If you have a periodic arrhythmic pattern, it's low risk, probably don't need to do much. If it's IIC, I think most of us use an anti-seizure medication plus or minus a benzodiazepine. I've always favored anti-seizure medications. Feel like they're less sedating. It's more reliable to follow their clinical exam. If they have an EEG and clinical improvement, kind of know what the next steps are, continue to escalate along those lines. If you have an unclear response, you have this 2 Hertz LPD type pattern, you were you gave them an anti-seizure medication, they didn't really improve that much, but you're still very suspicious, that's when I think you consider one of these multimodal or ancillary testing approaches. And then if it's negative, you can continue to follow clinically. If it's positive, maybe that's indicative that you're a bit more aggressive. So in summary, IIC patterns, the EEG only sees a part of the problem. You can look at some of these other modalities to get a much fuller understanding. I think treatment decisions really need to be tailored on an individual basis at this time. And it's not only the frequency of the discharges, it's also this fast activity that needs to be considered. FDG PET can be useful, as can MRI. And here are just a few additional resources and journals for those, or journal articles for those really interested in trying to delve into this topic more. And I'd just like to thank all of my collaborators who have been really interested in this question and trying to figure out how to better care for our patients. So I didn't go too much over time. Thank you.